Okay, so we're going to go over the shoulder exam. First, let's start by having him take his shirt off. Whenever you're doing a shoulder exam, you can miss a lot if you don't have the patient's shirt off. If it's a woman, ask them if they have a sports bra, if they're okay being in a bra. Make sure you have a chaperone. But we want to be able to look at them and look to see if we see any little nuances on the physical exam. So the way I do shoulder, I do inspection, palpation, range of motion, strength, sensation, and special test. One of the things I want to make sure I don't forget, so I'll say it right now, you want to do a good strength and sensation exam and Sperling's, because you can miss cervical pathology that contributes to shoulder pain or shoulder symptoms. All right, so just starting out, we're inspecting. We see he's got a nice little white beater t-shirt tan from being out in the sun, but I'm looking for symmetry. So I look to see if he's got a little bit more pronounced trap on the left compared to the right, and everyone's a little bit different. It's very rare to see someone who's perfectly symmetrical, but we're just looking. I don't see anything glaringly obvious. So palpation, the main thing that I'm going to do is I'm going to palpate over the trap, around behind the acromion, over the AC joint, biceps tendon, which is kind of tender regardless, so you want to compare side to side. You can feel along the clavicle, but pretty rare to have issues there, but that's the gist of it. Range of motion, let me have you turn face that wall. What I like to do is start with abduction, so bring your arms out over your head, and just do that a couple times. And this is one of the ones where you really want the shirt off. What I'm looking for is for scapular dyskinesis, so we're looking at the muscles. You see again, he's got some asymmetry where he's got more muscle mass here than he does there. So did he have an injury, or is he just right-handed and he's got more muscle bulk there? Are you right-handed?
Yes, I am.
Okay, and you see how he's a lot more raised on the left-hand side there. But I'm watching the scapula move and seeing if they're discordant or if there's any other kind of asymmetry like that. Now forward flexion, bring your hands forward, up over your head, and then just note how far he gets. Should be to 180 without pain. If he has pain, you document that. And then drop your arms, and let's do come up the back, so hand up the back. We're doing internal rotation, and then document nipple line is T4, belly button T10, and then compare side to side. He's a little bit restricted on that side, and is that because he's got more muscle on that side? Could be. Do you have any shoulder injuries on this side?
Mm-mm.
So it's probably just his handedness, and you can take that down. You can do also turn face us. You can do external rotation like this, see how they look, and then back down, and you can do it up this way and then down like that and see if they've got full range there. But the main ones I'm doing are abduction, forward flexion, and then internal rotation on the back. So that's the gist of it for inspection and palpation and range of motion. So then what I want to do is I want to get into the ones that I don't want to forget. So I'm going to start with the Sperling's. What I like to do is I turn the head to the side and then tilt it back and then axial load. So again, turn, tilt, axial load. And if they have shooting pain down into the arm, concerning for a herniated disc. For strength, I'm not very bright, so I like to try and remember the simple things. So I start with blocker. So this is C5, and then beggar would be like this, hands like that, but I do it this way. Kisser, kiss the hands. You'd have your hands like that, kiss the hand, but kiss her, and then grab my fingers. That's grab her, and then Spock, relax. Go like that. You can have them try and split their fingers like that, or just spread the fingers and kind of feel to see if they've got good abduction strengths. And that's C5, 6, 7, 8, T1 respectively for blocker, beggar, kisser, grabber, Spock. And then I always have the patient in anatomic position, hands out. Remember 6 shooter. This is 6, C6 right here, so this is C5 roughly. C6, middle finger C7, little finger is C8, and then T1 is right here. Everyone's variable, but it gives you an idea of what you should be expecting. So we've completed that. You can check pulses, make sure they've got a good a radial and ulnar pulse, not something we're usually worried about. So then I get into the meat of the exam. So I'm going to first check the rotator cuff, so arms out like this, and you want to bring them 30 degrees forward in the plane of the scapula as it lays on the back. Hands down. People argue about full can, empty can. I like an empty can. So push down and compare side to side, see if they have pain with that, and then elbows in at your side. Don't only push in. That's checking the external rotation teres and infraspinatus, and then subscap, don't only push out. Going like that, and then I'll have him put his hand on his belly, and then bring your elbow forward, doing the same motion. Some people put the hand behind the back and push off, but a lot of people don't have the flexibility to do that. So by doing this and having them push forward with their elbow, you're completing the same basic function of the subscap working. You can also do a bear hugger hand up here, don't pull away, and that's testing the subscap as well. So that's 3 different tests for the subscap. Resisted internal rotation, I call this the Napoleon or the belly press test, where you're pushing the elbow forward, and then the bear hugger hand up here. I then take them into speeds, so arms straight out in front, don't only push down, and that's checking for biceps tendinopathy. And then active compression test, which tests for the AC joint and also for the labrum. If this hurts them deep in the joint and this doesn't, speeds, active compression tests comprise the O'Brien's. If this doesn't hurt, this does hurt, that's a positive O'Brien's. If this hurts and this hurts, equivocal. If this doesn't hurt and this hurts, probably bicep. Okay? So again, speeds, active compression test, and the speeds is directly in front, active compression 10 to 15 degrees across. And then you're right in line to come across here, and we do a scarf test, checking for AC pathology. And then some folks do this one where they put the hand on there and say don't only push down. And again, those are just 2 different tests that'll cause pain if they have impingement on the AC joint. You can also kind of palpate or squeeze right on the AC joint, but I like direct palpation. And that's the labral test, and then rotator cuff test. And then the other labral test that I don't want to forget is this one called bicep load 1. So don't let me move your hand, I'm going to keep it right there. Bring them up to 90 degrees and go like that, and then relax. Come up to 120, and this is biceps load 2, and it's supposed to be most specific for labral pathology. What you're doing is kind of, don't let me move you. You're creating a lever arm that's jamming the humerus into the labrum if it's injured, and that's painful. There's one other test that I kind of like, and that's called the, I don't even know what the name of it is, but I call it the Egyptian. If you bring them up, externally rotate, and then go like that, if that causes pain, it can be indicative of labral pathology as well. So you've got O'Brien's, biceps load 1, biceps load 2, and what do we call that? We call that the Egyptian. And then we go into impingement. We have nears, where you take the arm. I like to block the shoulder because you're trying to press the supraspinatus underneath the acromion, and I take the arm up and see if that causes pain. Going near to the ear, so pronated and near to the ear. And then Hawkins, I just take the arm, and again, you're just trying to compress the supraspinatus, so I kind of take them across like that, and those are the 2 impingement tests. And then to finish off, usually you're going to be specifically looking at this. I do a sulcus test, see if there's a gap created because he's got weak inferior glenohumeral ligaments, and then I do apprehension test, and what you're doing is basically creating a fulcrum and trying to dislocate a shoulder. Apprehension, you can do laying down, you can do the relocation, and then surprise test as well, or other extensions to that, but that's the gist of the exam. You don't have to do those tests for shoulder subluxation unless you really think that that's what's going on, but it's better to just go through the whole thing and remember to do it. So I do it on every exam. And then I want to give a shout out to Mark Hutchinson, because he's got a lot of good videos out there on the internet as well. And so there you go. Thank you.